But if it were up to me, if I could play the sci-fi scientist for a second and I ran one of these companies, not only would I lawfully collect as much as possible, and including and in particular the component that I'm talking about at every level of care delivery, I would then place all of it into contextual learning and combine it with the best of everything we have and then put it all together and sell it back to every customer and every medical school on the planet.
All is working, trying to relax. Up in the capsule, sent me up a drink. Jokes, Major Tom. The count goes on. 4, 3, 2.
Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you the hottest and most crucial conversations in healthcare and physician leadership. Today, we are going further than we have ever gone before. We're going into the future, and because of the risks involved with that, we are going solo today. No guests today. So hit pause or stop now if you prefer a guest over my ramblings. With today's episodes, I certainly did not want to embarrass anyone as a guest as I spell out some random thoughts about the future. Why talk about the future? And what does this, if anything, have to do with the role of the Chief Medical Officer? Here's what I mean, and let me set this up for you. Every few weeks, someone sends me material to read about the sad state of affairs that we have in U.S. healthcare, which, of course, if you're a regular listener, is simply shocking, utterly shocking, in fact. It's like that famous line in Casablanca when Captain Renault shuts down Rick's Cafe and proclaims, "I'm shocked to find that gambling is going on in here," while he takes a pile of cash as winnings from one of the casino staff. If you're any type of regular or intermittent listener to this podcast, it is likely that at some level you are concerned about healthcare. Another shocking revelation, I know. And even if you're even remotely a bit concerned about healthcare, you know that there is a list a mile long of the things that are so messed up and messy all together all at the same time. But despite your full awareness of the messy environment in which you work, you may not have the time or energy to think about the future. You're simply too busy putting out fires from the combustible materials that were set up long before you even stepped into your role. On this podcast, I've interviewed quite a few physician leaders, most of whom have been a CMO or CMO-like leader, and the rest have been leaders in the fields of leadership development and key stakeholders in understanding the sorry state of affairs in healthcare with insights on how to be effective in the current environment. But I've yet to interview anyone who speaks about AI, which besides the number one question that I always get asked about whether to still practice medicine while in the CMO role, the curiosity about AI lurks in the background as a close second. But it's also a question that folks in medicine ask because, quite frankly, they don't know how best to frame it in the context of the CMO. So I'm going to give it a shot for you. And I have some ideas on how you, as a CMO, might consider what's happening in at least one domain of AI and what may happen in the future or maybe your future. So if you're working in a moderate to large size healthcare system that provides clinical care at some point in the recent past or near term, you have probably been introduced to ambient AI, the kind of platform that allows practitioners to have their encounters recorded and processed for placement into your medical records, right? And just like the original transcription services, the initial computerized medical records, the eventual large-scale EHR rollouts, and voice recognition software, you're somewhere on that change management curve with your med staff in terms of like those early adopters, those late adopters, the cynics, the skeptics, and even the paranoid. But in the midst of all that change management work that you're leading is the mere fact that you're just trying to get the utilization of the product to scale up in your organization so that all of that time, the energy, those meetings, the cost, and the hopeful outcomes meet the goals of your organization. And further, those goals are stated in frames such as easing workload for the doctor, simplifying the chart work and documentation, offloading extra work, and always decreasing that so-called pajama time charting. And in some cases, there may even be an underlying goal of increasing efficiency such that the docs can see more patients and drive volume and revenue as either to offset the ambient AI expense or to actually drive both top line and bottom line revenue streams. Most of the ambient architecture is somewhat stationary, but some systems, I suspect, if they haven't already, they're likely moving in the mobile direction wherein the physician has a wearable and maybe even a body cam component too, like to capture everything, everywhere, all of the time. So not just stationary in the exam room in the clinic, but picture the hospital environment and picture where every clinician, the nurse, the tech, the resident, the attending, they all wear these small devices similar to the traditional Vocera. And there's cameras on these devices and they're always on for every encounter, like even pre-op holding inside the OR, the PACU, the ED, the behavioral psych unit, you name it, all of which is designed to capture the content to create the digital record of the encounter. Now you got to stay with me here because this is where it may sound really spooky and sci-fi and feel free to pause or stop listening. If you've never had a moment to consider this, consider every interaction, every decision, every tone of voice recorded, anonymized, and fed into some giant data lake in the cloud. And all of it resides there as both content and context. And sitting in some sort of anonymized, HIPAA-compliant database of contextualized encounters. And at first, this sounds horribly intrusive, almost sounds illegal. Big brother in the OR. But pause on that for a second. Pause on this concept for a moment. The digital information is already being collected if you're working in an ambient AI system right now. And there are disclaimers by all of the big vendors and creators for folks to opt in, to opt out about how that information is held and how it is to be used and what might happen in the future. And you can go out and read AWS Health Scribe, Microsoft Azure, OpenAI, Google's Vertex AI as sort of the early infrastructures and their what they post as their disclaimers about their encounter data. But this is also very much true for Nuance DAX, Copilot, Suki AI, and Abridge, to name a few. And they all have very similar statements as they relate to their business agreements, their compliance, the security, the de-identification. I mean, nobody is going into this lightly. And it basically set up a structure where most folks that are going to use these products simply accept that the end user, you and your fellow clinicians, and of course the patient, are like the key beneficiaries. And let's not at all forget what Epic is doing with all of their encounter information, since they have a large share of the market in terms of medical record and medical documentation. But if it were up to me, if I could play the sci-fi scientist for a second and I ran one of these companies, not only would I lawfully collect as much as possible, and including and in particular the visual component that I'm talking about at every level of care delivery, I would then place all of it into the LLMs for contextual learning and combine it with the best of everything we have and up to date and open evidence, what they have to offer, and then put it all together and sell it back to every customer and every medical school on the planet. So look, first, this becomes a differentiator in the delivery of care. And second, it is because this is exactly how we operate in every other high performance field, right? So airline pilots record every flight, athletes review every play. Robotic surgery manufacturers have been recording for quite some time every movement for the sake of teaching and quality control. So why not in medicine in general? Airline pilots use simulations and then they have thousands of hours in the air. The value of what I'm describing isn't in the surveillance or raw data, not the form, but the function. It's in the capture of the context, which before AI was really not feasible on scale, but now it is, right? So think about open evidence accumulating tremendous medical knowledge with amazing abilities to analyze and investigate challenging questions and prompts and situations in the clinical care and delivery of medicine. But the application still requires the skill and the judgment and of the physician or the user and the context by that using physician. What if you could place all of the clinical years that are captured over a multitude of encounters put that in that AI platform and begin to use that to improve care delivery. So today there's a human interface, the physician, that's holding all this accumulated training, knowledge, and unique skill set. And the physician is the interface between the patient and all of that stored in their brain and their experience and their training. But what if that interface was smoothed out, flattened, made friction free? Basically, you just jack right in at scale to not just your own clinical experience of 15, 20, 25 years, but how about a few 100,000 physicians mapped right into your workflow with that unique patient right then and there? Imagine what happens when you have millions of real world micro interactions analyzed by AI, the patterns of communication, the tone, the body language, the timing, the decision cascades. And if we took all those contexts, fed them into the large learning and language machines, and then asked agentic AI to become more replicative and representative of real world cases filled with all that nuance, all those patterns, all those scenarios, and so much more, such that now AI produces the best known choices for any patient based on millions of aggregated contextual experiences and outcomes, particularly if you take what's in the medical record, their socioeconomic background, their family history, put that all together and use this type of algorithmic output in real time, and further create simulations with the same information for our new learners in medical education. We can twist the paradigm just enough, and now we find ourselves with a new use case of AI with this massive context capture that I'm talking about, the medical record, the medical knowledge in the form that I'm describing. We, the proverbial we, suddenly have the ability to use AI to really improve care. And we could use it to train all of our learners in things such as empathy, general situational awareness, teamwork, all derived from this contextual intelligence at scale. And then starting as early as desired in the medical education process and longitudinal from day one if you wanted. All this body cam captured data that I'm referring to, ethically handled, de-identified, structured for simulation, lawful and correct, could become the new currency of medical education and medical delivery of care, if we're brave enough to use it. The irony is that the technology already exists, and many of the show's listeners already know that AI is being used in personalized interactions and in a way that has gone way beyond the traditional chatbot or avatar. There are agentic AI systems that are capable of better and better interactions with humans, particularly in the form of what I call cybernetic relationships. And they're being used to interact with people and talking about their loneliness or their mental well-being or sharing their deepest secrets or fears. And in these cases, in these use cases, AI is becoming somewhat hyper-agentic, my term, made-up term, but is becoming responsive in ways that are freaky and unimaginable, but yet they're actually happening. And I don't want to go down the rabbit hole of, oh, this is terrible, this is wrong, this is horrible. Let's just stay with the moment. The problem really isn't invention, it's permission. The hospitals are undoubtedly afraid of everything I'm talking about, particularly the liability involved with a body cam and this type of AI architecture. And yet I know that the security officers in hospitals do use body cams on the staff to manage violent patients. So if we're already using some form of it, it's not that hard to begin to think farther downstream about it. Undoubtedly, universities fear the disruption of the entire teaching apprenticeship model in medicine and all the downstream effects. And yet it could help with some of the choke points in terms of faculty growth and increasing medical school size and learning opportunities. Healthcare certainly doesn't lack any efforts at innovation nor any fear or any amount of inertia to change, but sometimes it has a real imagination shortage. For centuries, medicine has been built on the hierarchy of knowledge. And clearly for the last 100 years or more, it's been very institutionalized as a hierarchy. Those who knew the most held the most authority. The attendings over residents, the residents over students, the physicians over nurses, the specialists over generalists. But what happens when the algorithm sitting in the corner can work a problem with more encounter knowledge and scientific research than ever possible in human history before, especially since medical knowledge has exponentially increased to the pace of doubling 72, 73 days or so. And that was what was predicted about a decade ago. So what happens when clinical reasoning is accessible by embedding all the context? And what if the so-called 10,000 hours of practice or 10,000 hours of training is not the bare minimum anymore, and all the hours are digitized into AI models, collated, sorted, recognized, and used for outputs? And what happens if all of that captured video by the robotic surgery manufacturers, which are being used as training tools and for quality improvement today, but ultimately for true robotic surgery with the physician and the team standing nearby for added safety and oversight, just like an airline pilot? What if we do, as I suggested earlier in this podcast, and combine the vastness of hours of context acquired by the imaginary body cams with all of the increased knowledge in medicine, and now we have facts and context, content and experience. And in that world, the value of the human clinician changes completely. It's no longer what you know, it's what you can interpret and how you apply judgment, empathy, context, decision-making. And it's also how you lead as a human. Artificial intelligence won't erase physicians, but it will reshape them. The knowledge will be democratized, instantly searchable and always current, and potentially contextual. That's going to flatten the hierarchy, and it will challenge every title and every credential that has depended on it. And it's uncomfortable, but it can also be very liberating, because for the first time, the best idea in the room might not depend solely on seniority, but only on clarity. In ambiguity, leaders bring clarity. And that means medical student or medical assistant or even the patient could surface an insight right then and there that transforms the decision-making and the care delivery. Look, at some point, let's embrace and empower the next generation and help them to work collaboratively with teams and with patients and with caregivers to generate the most holistic insights onto the most transformative care possible for any single patient and any given time. It takes personalized medicine to a whole new level and provide an environment that allows for a level of vocational excellence rather than power dynamics of hierarchy and hidden knowledge. As for the technical proficiency in the hands of surgeons and proceduralists, it really is the same thing. Look, why does a surgeon need to master organic chemistry in the pre-medical curriculum? What is the point of that? Does the pilot on your airplane need to master calculus, or do you need proof that at age 17 they mastered it, or in college? And yet you trust him or her with your life every time you fly. And I'm betting that most of you fly way more often each year than you do undergo any type of operation or procedure. The hours and hours of airplane training can be done, and it can be done just like it is for invasive surgery. It's just a matter of willingness. And what I'm saying is that the imaginary structure is accessible to shift both our clinical delivery and our medical education and training from one that is a highly guarded and highly specialized marathon from which you generate experts into an entirely new future state. The old rules in which folks like myself learned the ancient art and practice of medicine no longer needs to be saddled with what appear to be unsustainable guardrails going into the future. But rather, we need new rules and work structures that can replace the old and allow for highly skilled and exceptionally highly trained workers to succeed. And they can still, and we all can still, consider it a privilege to practice medicine and a calling. It's just different. We shouldn't think of AI as dropping in and improving workflows. I think we need to begin to think about AI and brand new workflows and a new future. Just noodle on that for a while, or at least till next week when I have a guest on the show. But yeah, one more thing, something even more disturbing that folks will not say out loud. When you look at the demographics of the labor workforce in the United States, Healthcare already employs roughly 10% of the U.S. workforce, making it one of the largest employment sectors, surpassing many other large sectors such as manufacturing, retail, education, just to name a few, in sheer size, 17 million people. Yet we still treat provider education and training as a niche pipeline issue rather than a major labor system strategy. If 1 in 10 jobs is in healthcare, then rethinking how we train those jobs isn't just a medical education issue. It's a workforce and economic imperative. There is zero chance that we will return to manufacturing in numbers that will eclipse what we think we have today or what we think we want in the future, and certainly won't eclipse what our needs are relative to healthcare right now. And maybe over time that will happen, but no one seems to even know that what we're even manufacturing 5, 10, 15 years from now. And beyond that, with the silver tsunami upon us, there will be an ever increasing need for a larger healthcare workforce. And so it is exceptionally challenging to imagine that any other sector is growing fast enough to overtake healthcare. And not to punch you when you're down, healthcare is a key component to our economic well-being. Look at it this way. In an economy where the Magnificent Seven or the Fantastic 10 are driving stock valuations on the stock market to record highs, and at some point they may lose their growth halo, the real engine of growth and employment is still anchored in, yes, you guessed it, healthcare today. With nearly 18% of GDP and escalating spending, the sector is not just a service, it is a pillar of the U.S. economic infrastructure, like it or not, and it cuts both ways. I mean, everyone is looking to reduce cost and expense, particularly inside the hands of middlemen in healthcare, but no one really knows what will replace those dollars if they're taken out of the system. And if it really is consolidated wealth in the hands of just a few powerful shareholders, that in and of itself is its own problem. But if the dollars spent in healthcare keep people employed and spending money on other goods and services, maybe we need more activity and not less. And I'm talking much more broadly than the nurse at the bedside. When I called my pharmacy benefit manager, and we can criticize PBMs all we want, that's a person who's getting employed to carry out a responsibility to help me obtain my medication. So maybe we can do without some of the shenanigans of PBMs, but we probably still need people on the phone to help me get my medication. So when people lament that the government is spending too much today through the portal known as CMS, and yet at the exact same time, of course, paying physicians ridiculously low fees, it is in fact driving one of the major components of the U.S. economy, like it or not. But I digress. Let's go back to the future. So if the future state reimagines who we train, how we train, and redefines what we are actually training for at all, we might be able to agree that we will no longer train to memorize, but really to make meaning, to interpret data into action for human beings in need, and particularly when they're at their most vulnerable, to connect the people, the systems, and the outcomes in ways that today's ecosystem struggles and in some places cannot. The leaders who understand this shift will define the next 50 years of medicine. If you are leading a health system, an academic medical center, university, a foundation, or simply an investment portfolio, this next decade belongs to you. Despite all the noise coming out of the administration and all the struggles and all the compression of money, you are the only brokers that have the influence and the power, and eventually, if not now, hopefully in the future, the capital, to decide whether we keep tinkering at the edges of a 19th century model or whether we begin to build a whole new ecosystem, one that matches the world our patients are actually living in and day out. The healthcare workforce crisis isn't about shortages, even though mathematically it is. It's about a failure of imagination, and it isn't about innovation. It's a willingness to imagine a different state. Imagine a pipeline of medical education that starts even as early as age 18. This is happening in other countries and has for a long time. other than the United States, and in tiny pockets in the United States, 6 students in a medical school class here, 4 in another medical school class there. We're talking about adding an entirely novel training system that scales up to and through all of this captured experience and simulation, and placing all of that, all of those experiences and knowledge base into the hands of bedside learners and bedside physicians. Imagine a culture that values judgment over memorization. That's not science fiction. That's strategy. Is it helpful to move forward within a system designed for the past? Or is it better to embrace one bold enough that will shape the future? Leaders look to the future with a vision of how things might be, while at the very same time, they must accept the brutal facts of reality and how things really are today. But with innovative leadership, people bend reality, and they bend it just enough to create new paradigms. The iPod, the iPhone, the role of Amazon, and all these new paradigms and operating systems that we have grown accustomed to, other innovators created, and we use them regularly. Strategies are built on knowing the landscape, how it is, but also, more importantly, how it could be with the right systems and structures and processes and people in place. If you're a physician leader, or any leader in healthcare for that matter, consider that the vendors you are working with in this ambient architecture, that they're already talking about this, and probably other similar future states that I cannot imagine. Maybe you should ask to be part of these discussions and consider the value proposition of being first at the table to embrace the potential futures of care delivery. Maybe you even have ideas of your own on the matter for your own organization's mission, its values, its culture, its community. Ladies and gentlemen, you have been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. And if you want to learn more about what it is like to be a CMO, how to get on the path to becoming a CMO in healthcare anywhere, how to lead in healthcare now or in the future, check out our website, thefirechiefcmo.com, and connect with me on LinkedIn. If you have comments, feedback, critiques, criticisms, and insults, feel free to send those to me too. I don't care. I just simply love talking with CMOs. And now I think I love thinking about CMOs of the future too. So get out there, be a chief, be the future, and whatever you do, in the words of Sergeant Phil Esterhaus, remember, let's be careful out there.